Good evening, friends. We start with question. A person after road traffic accident operated of hip fracture, patient was shifted to ICU. Now patient develops suspiciousness over family members that they want to kill me, they want to take my property. Patient also visualize snake on floor. Please do reply. Yes. What is the answer? In this patient is having suspiciousness, means delusion, visual hallucination. Delusion, hallucinations are there. After a stressor, it may be considered as stressor. So diagnosis is, yes, please do reply. Diagnosis is acute psychosis. In the same question, if I add 2-3 lines, yes, patient is not oriented to time, place, person. Patient appears to be confused. Okay, his symptoms worsen in evening. In this question, I will highlight this confused, disorientation to time, place, person. So disorientation, which is acute, confused. If confusion word is there, acute confusion is there, acute disorientation is there, yes, please do reply. Neha, change the answer. Yes, now the answer is delirium. Means all these symptoms, psychotic symptoms may be present in delirium, and this visual hallucination, visual hallucinations are common in organicity. And you know, question is asked, most common organic mental disorder is delirium. In the same question, if I add one more line, that patient is taking, yes, patient is taking alcohol for last 10 years, 15 years, now he is not taking alcohol because patient is admitted, means these symptoms are due to alcohol withdrawal, and diagnosis would be delirium tremens. Clear? So same question they will change nowadays in INI-CET. They are asking same topic again and again, and they change few statements, few lines are twisted and answer is changed. Means if only delusion, hallucination are there, acute psychosis. If disorientation is there, confusion state is there, then delirium. And if this delirium is due to alcohol withdrawal, then it is delirium tremens. Okay. Now, a question was asked long time back, is in psychotic disorder, delusion and hallucination are present in clear sensorium. So wherever you find acute confusional state, altered sensorium, clouding of consciousness, drowsiness, diagnosis would be delirium. You will find many questions in which there is electrolyte imbalance, burn is there, history of burn, electrolyte imbalance, hip fracture, patient shifted to ICU, and now he is behaving very violently, he is pulling cannula, he is pulling nasogastric tube, he is suspicious over family member, he is abusing everybody. These symptoms are there, and they said that patient is disoriented to time, place, person. Diagnosis would be delirium. In this question, they have given his symptom worsen in evening. Yes, this is sundowning phenomena. Sundowning phenomena. Now, why I am so much concerned about delirium and delirium tremens, I will highlight delirium tremens. The treatment is totally different. In delirium, we say the treatment is treat the cause. Treat the cause. Suppose delirium is due to electrolyte imbalance, we will correct electrolyte, patient would be okay. If psychotic symptoms are more disturbing, then you can add low dose antipsychotics. So in delirium, treatment is low dose antipsychotic. In delirium tremens, yes, you will find the treatment is IV lorazepam plus IV thiamine plus IV dextrose. So question has been asked, IV lorazepam means benzodiazepine. We will add thiamine in all disorders related to alcohol. Treatment part will include thiamine. Wernicke's encephalopathy, IV thiamine. Korsakoff psychosis, oral thiamine. Alcohol withdrawal, symptoms, detoxification. Yes, in alcohol withdrawal again we give thiamine. Okay. A question was asked recently that thiamine is given first or dextrose is given first. First of all, you will give thiamine, then dextrose. In biochemistry, we have read that carbohydrate metabolism require thiamine. If patient is taking long time alcohol, thiamine is already deficient, and you give carbohydrate, dextrose, the remaining thiamine will be utilized by that carbohydrate and there would be acute thiamine deficiency. So always give thiamine first, then dextrose. So treatment is totally different. One more point, we avoid antipsychotic in delirium tremens because antipsychotic lower the threshold of seizures, and in alcohol withdrawal there may be seizures. Let me discuss one question, recently asked question. The patient is a chronic alcoholic with a history of 10 years of alcohol consumption. His last drink was 2 days back and he presented with seizures. Alcohol withdrawal may present with seizures. Question is asked, generalized tonic-clonic seizures, and these seizure comes in clusters. These means in a short span multiple seizures would be there, and altered consciousness, altered sensorium. I told you if altered sensorium, altered level of consciousness is there, diagnosis is delirium. And history of alcohol is there, delirium tremens. Other than history of alcohol, symptoms would be autonomic disturbances. Okay. So what is the treatment approach? I just told you we will give benzodiazepine. In this question, lorazepam is not given. We will give diazepam. Actually, diazepam also take care of seizures. In alcohol withdrawal seizures, we give IV diazepam plus IV thiamine. If in this question they have given diazepam, if lorazepam is there, lorazepam would have been better option. But in this question, diazepam we will give, thiamine we will give. So answer is yes. Please do reply. We have very good. Answer is D. In alcohol detoxification, we use benzodiazepine. Question is asked, drug of choice for alcohol detoxification. Alcohol detoxification, chlordiazepoxide. Yes, but a patient is there in emergency, your liver function test machine is out of order, means you can't determine liver function test, you can't give chlordiazepoxide. You will prefer short acting benzodiazepine, lorazepam, oxazepam. Multiple time question. Yes, these lorazepam, oxazepam are short acting and they are metabolized by liver by conjugation, not oxidation. They are metabolized by conjugation, means if liver function is deranged, even then you can use lorazepam, oxazepam. 3-4 times question has been asked that they asked a person is sitting in periphery in PSC, a patient came taking alcohol for last 15 days. Now you want to detoxify, you have no lab facility, which drug you will prefer? Lorazepam, oxazepam. You are sitting in emergency, your liver function test machine is not working, which drug you will prefer? Lorazepam, oxazepam. Now, this is very, very important. DSM-5 said, if you want to make the diagnosis of schizophrenia out of these delusion, hallucination, disorganized speech, means formal thought disorder. Yes, I will discuss formal thought disorder in mnemonic form. Disorganized or catatonic behavior, negative symptoms. Out of these, if 2 or more than 2 symptoms are present for more than 6 months, then the diagnosis is schizophrenia. I am taking DSM-5. So In ICD-11, the criteria are, duration criteria is different, so don't get confused. Remember DSM-5 first, 2 or more than 2 symptoms, then diagnosis is schizophrenia. If 2 or more than 2 symptoms for 1 month to 6 months, diagnosis is schizophreniform disorder. Schizophreniform disorder. If less than 1 month, yes, less than 1 month, then it is brief psychotic disorder. Brief psychotic. I will make a flow chart. It will help you to solve multiple confusing questions. Yes, brief psychotic disorder. To be more precise, as they are asking questions deeper and deeper, so you will remember brief psychotic disorder, 1 symptom is sufficient. What I said? Only 1 symptom is sufficient for 1 day to 1 month. To be more precise. So brief psychotic disorder, 1 symptom out of these, for 1 day to 1 month, brief psychotic disorder. In ICD-11, the name is ATPD. So same question may be asked and they can give ATPD in the option in place of brief psychotic disorder. Yes, acute transient psychotic disorder. And fever is stressor for ATPD. Yes. Or common name to ATPD or brief psychotic disorder is acute psychosis. Acute psychosis. Now, you will tell me answer of this question. Before that, let me tell you one entity that is called persistent delusional disorder. Persistent delusional disorder, only one delusion is there. Everything is okay. Patient is well-behaved gentleman, talking nicely, yes, polished shoes. Everything is okay. Only one delusion is there that my wife is cheating on me. Means he will do all his work, but whenever you will touch the domain of his wife, he will become angry, yes, and symptoms will worsen. These symptoms continue for more than 1 month. More than 1 month, that is persistent delusional disorder. I have taken age of this patient 41. Question has been asked, the common age of PDD is, yes, 40, middle age. Middle age. A question was asked, which of the following is not characteristic of persistent delusional disorder? And one option was early age. No, PDD is in middle age. Male always doubt his wife that she is cheating on him and fights with her without any reason for 1 year. More than 1 month, long duration 1 year. Yes, patient report occasional hallucination. Point it out. In PDD, mainly delusion is there, but occasional hallucination may be present. Point it out. Occasional hallucination may be present in PDD. Rest behavior is normal, well-behaved gentleman, talking nicely, doing his work nicely. Yes, the diagnosis is persistent delusional disorder. Yes, answer is very good. You have given correct answer. Now, in the same question, I ask you that I removed this word. Now tell me the answer. Yes, please. Now tell me the answer. Now they say 41-year-old male cheating, yes, feel that wife is cheating on him, that is delusion is there. Delusion is there and hallucination is there. Delusion, hallucination more than 6 months. Yes, more than 6 months, 1 year. The diagnosis would be, yes, very good, schizophrenia. The diagnosis would be schizophrenia. So I make a flow chart. Clinical questions are asked, only one word is changed, answer is changed. So this flow chart will help you. If only delusion is there, less than 1 month. Less than 1 month. Yes, delusion, hallucination is there. Only one symptom is there, less than 1 month. Please do comment what is the answer. Yes, what would be the diagnosis? What would be the diagnosis? Brief psychotic disorder. I just told you. Yes, I just told you. If 1 day to 1 month, yes, only one symptom is sufficient to make the diagnosis of brief psychotic disorder. Now, only delusion is there. Yes, delusion is there. yes, plus occasional hallucination, Diagnosis is, yes, persistent delusional disorder. Okay. In the same question, suspiciousness is there, means many times they will not tell you the delusion, they will use the word suspiciousness is there. Suspiciousness is there, hallucination is there, less than one, brief psychotic disorder. Suspiciousness is there, occasional hallucination is present, diagnosis is persistent delusional disorder. Delusion is there, plus hallucination are there, delusion plus hallucination, both are there, yes, more than 6 months. Diagnosis is, yes, schizophrenia. Here point it out, I will add one more point, more than 1 month. This was less than 1 month. So if delusion is less than 1 month, brief psychotic disorder more than 1 month, persistent delusional disorder, delusion plus hallucination, schizophrenia, only suspiciousness is there. Suspiciousness is there, no delusion. Yes, onset adolescent, in adolescence, then it may be paranoid personality, Okay, very good. Yes, brief psychotic disorder or ATPD, yes, good. Now, update, all of the following indicate good prognosis in schizophrenia except, yes, please do comment, what is the answer? Yes, late onset is good prognostic factor, early onset poor prognostic factor. Family history of depression, good prognostic factor. Yes, family history of schizophrenia, yes, very, very important. Family history of schizophrenia, usually questions are asked, if family history is there, they usually say it is good prognosis or poor prognosis, but in this, if family history of depression is there, it is good prognostic factor. If family history of schizophrenia is there, it is poor prognostic factor. Developing country is poor prognostic factor. Yes, this is recent update. Previously, we used to say that developing countries are having better prognosis for schizophrenia, but now synopsis latest edition, yes, positive prognostic factor living in developed country. Okay, positive symptoms means delusion, hallucination are good prognostic factor, negative symptoms poor prognostic factor. So this is a potential question, latest update according to synopsis 12th edition, yes, developed country is a good prognostic factor, developing country poor prognostic factor. This question, a patient diagnosed with schizophrenia was suggested with risperidone, means patient is on antipsychotic. This is second generation antipsychotic, okay. After the intake of medication, the patient presents with at the OPD next day reporting symptoms of uprolling of eyeball. Yes, whenever we give antipsychotic, first generation, second generation antipsychotic, you have little bit idea. First generation, just like haloperidol, second generation, olanzapine, aripiprazole, risperidone. Yes, first generation D2 antagonist, second generation dopamine serotonin antagonist, we all know dopamine serotonin antagonist. First generation mainly act on positive symptoms, second generation act both on positive and negative symptom. Extrapyramidal symptoms are more with first generation antipsychotic, although in this question they have given second generation, but second generation also cause extrapyramidal symptoms, but extrapyramidal symptoms are more common with first generation. In this question, uprolling of eyeball, that is acute muscle dystonia, oculogyric crisis due to contraction of extraocular muscle. Yes, and acute muscle dystonia, before solving the question, let me discuss extrapyramidal symptom more frequently associated with first generation. First is acute muscle dystonia. A patient came to me, I started antipsychotic. First generation haloperidol, patient took 1 dose, in the evening patient came to emergency, uprolling of eyeball, extraocular muscle contraction. Lock jaw, unable to open the jaw. Yes, torticollis, that is acute muscle dystonia, earliest EPS, no need to worry, just give injection benztropine, promethazine. So benztropine, promethazine, you will give injection and patient will improve. Yes, it should be given intramuscular or IV. Yes, it can be given intramuscular or it can be given IV depending on the response required. If you want 10-15 minutes response, then intramuscular, immediate IV. Okay. Acute muscle dystonia in this question, acute muscle dystonia, answer is promethazine. We will not stop antipsychotic. Okay. Akathisia. Now this patient is taking antipsychotic. We ask the patient to follow. After 2 weeks, 3 weeks, patient came to you and said, Dr. Saab, now I am feeling better, my symptoms are improving, but Dr. Saab, I am having restlessness. What patient said? I am having restlessness. Means patient is reporting restlessness, subjective restlessness. Immediately attendant said, yes, Dr. Saab, he is unable to sit at one place, he is going out, coming in, up, down, in, out, not sitting at one place. Means that is objective restlessness. So subjective and objective restlessness, akathisia. This is most common EPS. Question has been asked, treatment is, yes, try beta blocker, you can give beta blocker. And if asthma is there, then you will give trihexyphenidyl. Okay. So both question has been asked. Akathisia, best drug, beta blocker, but few patients are asthmatic, then you can't give beta blocker, you will give trihexyphenidyl. Tardive dyskinesia. Now patient is taking this antipsychotic for years, months. Yes, after 1 year, 2 year, patient came having perioral movement, just like an old person without teeth. Suppose a young patient, 20-year-old, develops schizophrenia. Most common age of schizophrenia is adolescent and young adult, around 20 years. He is taking antipsychotic for 5 years, 10 years. Now he's a bank manager, maintaining well. But he started having tardive dyskinesia. Whenever a lady comes, he do like this, daily bitten. Okay, actually, so disturbing it is. Yes, why I am mentioning this? Because if tardive dyskinesia develop, it is very difficult to handle. Because long suppression of dopamine receptor leads to hypersensitivity of dopamine receptor. Tardive dyskinesia is due to, yes, upregulation of D2 receptor. In this chorioathetoid movements would be there. Okay. Sometimes it is also called rabbit syndrome. Yes, sometimes students say, sir, ek baar aur. Rabbit syndrome. Okay. In this, what you will do, you will give antipsychotic. You will stop antipsychotic because there is upregulation of dopamine receptor, and when you will stop antipsychotic, his symptoms will worsen. Point it out. So you will do counseling. Initially, your symptom will worsen. Then we want to give antipsychotic which can take care of psychotic symptoms. We want to give that antipsychotic which is having least extrapyramidal symptom. I told you tardive dyskinesia is EPS. So we will give clozapine. We will ask this person to brush with clozap. Okay, mnemonic, clozapine. And for this upregulation of D2 receptor, valbenazine, recently approved by FDA. Tetrabenazine, valbenazine. This question recently asked, very important topic, treatment resistant schizophrenia. 50-year-old patient, psychotic symptoms, drug A was prescribed, patient did not improve with haloperidol, first generation thyroidine, first generation, patient improved with this drug but developed increased salivation. Yes, increased salivation, hyperlipidemia, increased blood glucose. What is the drug? First of all, before solving the answer, yes, clozapine is used for treatment resistant schizophrenia. When you will say the patient is having treatment resistant schizophrenia, a patient came to me, I started first generation. No. I should start with second generation. This is controversial. NICE guideline says that if a patient comes to me, Yes, synopsis also latest edition clearly mentioned that if patient comes to me first time, yes, I should start with second generation. Why second generation? As you know, EPS are more common with first generation. So we should start with second generation. So suppose I started with olanzapine. So I have discussed one more question here that we should start with second generation. In adequate dose 4 to 6 weeks, patient is not improving. Now I started patient on haloperidol, yes, 4 to 6 week, again no improvement. Means two antipsychotic preferably from different generation. This was second generation, this is first generation, okay. Two different generation I used antipsychotic for adequate trial 4 to 6 weeks, but no improvement. I labeled the patient having treatment resistant schizophrenia. Now this patient would not come to me, he will go to Nirmal Baba. Nirmal Baba, you know, yes, just little bit humor. In the last time of preparation, I would say that never ever feel stressed. Some humor should be in your life. Before exam, if you are stressed, definitely your outcome would not be high. So better to remain relaxed. Yes. So Nirmal Baba asked, do you brush daily? The patient said, yes, Baba. Which toothpaste? He said, Colgate. No. Use close-up. Yes, I made mnemonic close-up as clozapine. When he will do brush with close-up, he will be treated because treatment-resistant schizophrenia, drug of choice is clozapine. But clozapine, yes, when he do brush, he take a good sleep, means most common side effect sedation. As second most common side effect, whenever he used to brush, excessive salivation, every time salivation, siloria, excessive salivation. If he is doing brush very rapidly, it appears just like seizure, dose dependent, slowly, no seizure. Rapidly, looks like seizure, dose dependent side effect, generalized tonic-clonic seizure. Okay, if do brush nicely, no granule, agranulocytosis, okay. Agranulocytosis is life threatening. That's why whenever we start clozapine, we do check TLC, DLC every week. 2 times question has been asked for 6 months. NICE guideline says 4 months, but synopsis says 6 months. Question has been asked on 6 months, so you will remember 6 months. Okay. So this is very troublesome. A recent update, NICE guideline Morsday has given clozapine is available in injectable form. Injectable form. Yes. Okay. Now, injectable, long-acting injectable. Before going to further on clozapine, let me give one question which has been asked in AIMS. Long-acting injectables, how we give? By G-track technique. G-track technique. How we will do? We will do this, immediately slap. Okay? No, we will, yes, pull the muscle mass and we will inject. When we will remove needle, we will leave the fold. Then the pathway would be zigzag, so drug will not ooze out. So G-track technique question has been asked. So this clozapine, I told you treatment resistant schizophrenia, and clozapine is having anti-suicidal property. Suicidal property, you must have seen the ad of close-up. Pass out and you get a girlfriend after doing brush with close-up. That is, yes, anti-suicide. If you find a girlfriend or boyfriend, definitely you will not commit suicide. So, this is the fact that suicide is more common in singles. Okay, don't go with the Facebook. According to Facebook, the married person are the most unhappy person. But in real life, we say that single person suicide rate is more than married. Okay, and if he find the girlfriend, he would not commit suicide. Anti-suicidal property. And a last mnemonic, you must have seen that ad. The boys do like this and make a heart. Myocarditis. Myocarditis, one more side effect of clozapine. Okay. Now, a 45-year, this question, I again tell you, in INI-CET, they want to check your true knowledge. They will change only 1 or 2 words and answer would change. Okay. All in this question, a patient is shown, yes, standing in abnormal posture. You can't maintain this abnormal posture for hours, but this patient is standing in the ward with this posture for 1 hour, 2 hour. You go to ward, you ask the nurse what happened. Nurse said, Dr. Saab, I don't know, but he is standing like this. Means you have done nothing. Means patient spontaneously achieved this abnormal posture and maintaining this abnormal posture for hours. That is called posturing. Posturing means spontaneous. I will solve this question, don't worry. But before that, spontaneous. If patient achieve this posture spontaneously, then it is posturing. But if patient is lying comfortably and you are doing passive movement, yes, active movement. If I ask you to move hand, active movement. If I hold the hand and move, this is passive movement. If I do passive movement on this patient and I feel no resistance and I leave the patient in abnormal posture, yes, then patient maintain abnormal posture, yes, catalepsy. Patient maintain abnormal posture after passive movement, no resistance during movement. कोई resistance नहीं है movement में, final posture यही है, image यही है, answer would be catalepsy. If during passive movement you are feeling resistance, just like you are bending wax candle, then it is waxy flexibility. Means you are bending wax candle, yes, you must have felt that resistance. In the same way, patient movement would have that type of resistance, and when you will leave the patient in abnormal posture, patient will maintain that abnormal posture. That is waxy flexibility. Yes, means patient maintain abnormal posture, yes, but resistance is present. Now you will give me answer. What is the answer is this question? Please do reply. Yes, a 45-year man diagnosed with, yes, chronic schizophrenia have no resistance on passively movement during neurological examination. No resistance, passively movement and maintain abnormal posture for a long time. Answer please. Catalepsy. Answer is catalepsy. In the same question, I remove everything first of all. I remove this. No. Please do comment the answer. Means 45-year man diagnosed with chronic schizophrenia has resistance. They have not mentioned about the waxy word, but yes, resistance is present and maintain abnormal posture. What will be the answer? Yes. Yes. Shefali Rajat, yes, answer is waxy flexibility. Answer is waxy flexibility. In the same question, if I remove, yes, chronic schizophrenia, maintain abnormal posture. He is maintaining abnormal posture, means you are not doing anything. Then the answer would become, yes, answer would become, yes, posturing. Answer would become posturing. Now, last option, cataplexy. Cataplexy is seen in narcolepsy. Narcolepsy. What is cataplexy? Suppose I am having narcolepsy, I am standing, there is sudden loss of muscle tone and I fell down. Yes, means sudden loss of muscle tone of anti-gravity muscle, but there is no loss of consciousness. Point it out. Suppose this question is asked and they give in a dramatic way in medical, they want to confuse with medicine question. They will give you that sudden fall. Whenever there is history of sudden fall, you ask about the loss of consciousness. Many times in seizures, there is loss of consciousness, sudden fall is there. You will ask the patient, what happened? Patient would say, Dr. Saab, I don't remember. I was washing my hand, but after some time, I was found on the bed. What happened? I don't remember means loss of consciousness. But in this patient, cataplexy patient, there is no loss of consciousness. Patient knows, will tell you that sudden loss of muscle tone, that is cataplexy. Mnemonic. Lepsy is not present in lepsy. Yes, catalepsy is not in lepsy. Catalepsy is present in catatonia. What I said? Catatonia. So all these things are seen in catatonia. catatonia. I will point out recently 2-3 question has been asked on catatonia. Yes, catatonia is a separate diagnosis. Previously we used to say catatonia is catatonic schizophrenia, but now we found that catatonia may be present in other psychiatric disorder, and most common cause of catatonia is affective disorders. Affective disorders. Okay, then schizophrenia question has been asked. Okay, catatonia usually have which symptoms, on which questions are asked? Posturing, catalepsy, vexiflexibility, negativitism, echolalia, echopraxia. Echopraxia means you ask what is your name, patient say what is your name, where do you live, where do you live, you must have played that with your girlfriend, copycat. Yes, echolalia, mimicking examiner's speech. Echopraxia means suppose I entered the ward, I did like this, patient did like this, I make a story. Our HOD entered the ward and our HOD did like this, the patient did this, HOD got angry, put this person on ECT. Okay, actually our HOD was not angry because the treatment of choice of catatonia is ECT, but medical management means we can treat the patient with the help of lorazepam. So if question is asked initial management or medical management, lorazepam. Treatment of choice, modified is ECT. Treatment of choice, modified ECT question has been asked. This question, yes, please give the answer. Really difficult question, but recently on this topic, difficult question has been asked. So, yes, 19-year-old man with no psychiatric history who has been experiencing 4 days of irritable mood. Yes, irritable mood may be present in mania, hypomania, mood may be irritable or euphoric. If irritable is there, irritable mania or paranoid mania. Euphoric mania. Increased goal-directed activity. Goal-directed activity, psychomotor activity is increased in mania. Okay. Brought to emergency department, subsequently hospitalized. I highlight it. Subsequently hospitalized. Point it out. This is very important word. Patient says that he feels so good that he does not need sleep. Yes, in depression there is lack of sleep. Patient is unable to sleep. In the daytime, patient would be lethargy, tired. But in mania, patient don't require sleep. You will ask, yes, how much sleep did you have? Patient would say, Doctor Saab, I took 2 hours of sleep. I am very happy and I am very energetic. Means in daytime, patient is energetic. Actually, there is decreased need of sleep in mania. So does not need sleep. He has racing thoughts. Yes, thoughts are increasing in mind. In mania, you know, flight of idea is seen in mania. Yes. He is grandiose and recently credit card purchasing several watches. His most likely diagnosis is. So in this question, yes, before solving this question, let me discuss about BPAD1 and BPAD2. Yes, answer you have given BPAD1, correct answer. Yes, but before going to the answer, yes, for the time being, I tell you the answer is A. Okay, now I tell you BPAD, bipolar affective disorder, BPAD1, BPAD2, ICD-11 has classified. ICD-11, 10 was not, in 10, BPAD1 and 2 was not there. In ICD-11, BPAD1 and 2 is there. So, mnemonic 2 looks like H. H for hypomania. Okay, H for hypomania. So, I ask you a question, if a patient is there having depression, yes, it is unipolar depression. Okay, depression, major depressive disorder or unipolar depression, all are same. Again I repeat, this is very, very important topic. Difficulty level of questions which has been asked recently is really, really high. So you will keep in mind, highly productive. Unipolar depression, depression is there, again depression. Yes, recurrent depressive disorder. If more than one episode of depression, then it is recurrent depressive disorder. Now this patient came to you having hypomania I just told you if hypomania is there, you will make the diagnosis of BPAD2. BPAD2. So this patient is treated now. Now it develops mania. And if mania is there, yes, BPAD1. Mnemonic or concept, whatever you say, make this. If mania, if you find anywhere word mania without second thought, diagnosis is BPAD1. So in this patient, mania is there, hypomania is there, both are there, but we will give preference to mania. At this time we will say BPAD1. देख रहा है विनोद कैसे diagnosis बदली जा रही है? Yes, depression, unipolar depression, recurrent depressive disorder, BPAD2, BPAD2, BPAD1. Now, point it out. If now this patient comes to you having depression, now this patient comes to you having depression. Now this is called bipolar depression. Bipolar depression. Why? What is the difference between unipolar depression and bipolar depression? Why I am so much concerned and why questions are being asked? Unipolar depression, we give antidepressant. Antidepressant. Yes. Unipolar depression, we give antidepressant. In bipolar depression, never give antidepressant alone. Means you can give antidepressant plus mood stabilizer. So if patient is having bipolar depression, you will never give antidepressant alone. Suppose you are sitting on the consultant chair, you are JR and you are feeling very happy, not in mania. Patient came and you took history, you found the patient is having criteria fulfilling the diagnosis of depression and you prescribed antidepressant. Actually, you did not take the past history. In this patient, suppose in past manic episode was there, so this patient was bipolar depression. You will never give antidepressant alone. If you give antidepressant alone, after some time this patient may come having manic symptom. This is called switching. So this question was asked that if switching occur, you prescribed antidepressant alone in bipolar depression and switching occurred, what you will do? First of all, you will stop antidepressant because the cause is antidepressant, and then you will start mood stabilizer. Start mood stabilizer. Yes, depression 2 weeks. Yes, I will take your question or not related to the topic. Yes, depression criteria 2 weeks. Yes, almost 40% रिविजन हो चुका है, क्वेश्चन बैंक भी कर लिया है, बट जीटी में स्कोर इंप्रूव नहीं हो रहा. डोंट वरी डियर, आई विल टेल यू फ्यू थिंग्स how to perceive the result of these GTs so that you can perform better in your upcoming exam. So don't worry. Okay dear YouTuber, I will take care of that. Those, if you have any doubt related to your preparation, your anxiety and sadness of mood, or you can connect with me, okay, anytime dear. So yes, so this is about BPAD1 and BPAD2. Now, symptoms of mania, I will not discuss. You all know that over familiarity is there, over talkativeness, hypersexuality, decreased need of sleep, flight of idea, prolixity. Yes, that is milder form of flight of idea. Leave it. What is the difference between mania and mania? Two questions has been asked and both are really Vinod कौन है sir? You must have seen the movie, that web series Panchayat. In Panchayat there was a famous dialogue. देख रहा है ना विनोद कैसे बेवकूफ बनाया जा रहा है? तो that was the just to put humor. Okay? देख रहा है ना विनोद कैसे diagnosis बदली जा रही है? Okay dear? Yes. We come to differentiate between mania and hypomania. Recently question was asked in NEET. That was really difficult question. Yes, I will go to that question before that. In mania and hypomania, symptoms are more or less same. How you will differentiate? Main point is socio-occupational dysfunction. If patient is not able to behave properly in society, socio-occupational dysfunction is present, diagnosis is mania. If socio-occupational dysfunction is minimal or absent, diagnosis is hypomania, symptoms may be same. Okay, for your question purpose, when you want to differentiate between hypomania, mania, first thing which will come in your mind is socio-occupational dysfunction. Second is psychotic symptom. If delusion, hallucination means psychotic symptoms are there, diagnosis would be mania. If yes, absent to hypomania, or better to say, if delusion and hallucination, manic symptoms are there and delusion is there, without second thought the diagnosis would be mania. Okay, in hypomania delusion is absent. Hospitalization, if hospitalization is there means symptoms are so severe that patient can't do function in society, can't do function at occupation. Yes, if patient is hospitalized, he will not go to the occupation. So socio-occupational dysfunction is implied in hospitalization. So in any question is hospitalization is there, diagnosis is mania. So, and in hypomania hospitalization is not required. Now, more frequently asked question, duration of symptom, mania 7 days, hypomania 4 days. Hypomania 4 days. So which one is important? First three are more important than the lower one. Flight of idea present in mania, in hypomania prolaxity is there. Pseudo hallucination present in mania, hypomania absent usually. So this question was asked in NEET. They gave clinical scenario and symptoms of mania or hypomania, and they asked what is the diagnosis, it is mania or hypomania. There was no catching point other than pseudo hallucination. If pseudo hallucination is there, chances are there that patient is having mania. Okay, now this question, we solve this question. In this question, duration of symptom 4 days, which suggests hypomania. Duration of, yes, patient is hospitalized, which suggests mania. And I told you that if hospitalization is there, then we will not for 7 days. Again, I repeat, if hospitalization is there, this 7 days, we will not for 7 days. We will immediately make the diagnosis of mania on the basis of symptom and hospitalization. So in this question, the diagnosis is mania. And I told you wherever mania is there, without second thought, the diagnosis is BPAD 1. Clear? BPAD 1. Now you tell me answer of a question. Yes, please. Depression, 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 depression. What is the diagnosis? Recurrent depressive disorder. Recurrent depressive disorder. Now, mania, 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 mania. Yes. What is the diagnosis? Recurrent manic disorder. Option B, BPAD 1. Please do reply. Yes. Yes. In this recurrent depressive disorder, recurrent manic disorder, there is no such entity in psychiatry. Answer is BPAD 1. I told you if mania is there, BPAD 1. You will say, sir, in this only happy pole is touched, only mania is there, depression is not there. Why you are saying bipolar? Research found that these patients usually develop depression before the death of this person, means this is BPAD 1 in which depressive episode has not come till now. Okay, dear? Yes, I have discussed this. This is again I am repeating, recently asked topic, very very important clinical question. They can confuse you. So upper three are more important in deciding the deciding the diagnosis of mania and hypomania. Clearly written that if hospitalization is there, socio-occupational dysfunction is there, we will not wait for 7 days. We will immediately make the diagnosis of mania. Recently asked question in INI-CET. Type 1 is most commonly affected age. No, it is adolescent and young adult, just like schizophrenia. Okay, that is around 18-20. Yes, 18-20. Yes. So mnemonic BPAD 1. 1 means, yes, male female ratio is 1. Mnemonic. Prevalence is 1% around, 1 to 2% or 1%. Suicide rate is 10 around 10%, 5 to 15%. So Attempt to commit suicide or suicide rate is 10 to 15%. Prevalence in general population 1%. Equal in both male and female. BPAD 2 more common in female than male. Okay. Classificatory changes. Recently question has been asked. So you will point out these tables I will give you, mug them up. Okay. ICD-11 included, which of the following diagnoses now included as OCRD? Yes, all these are impulse control disorder. Impulse control disorder according to ICD-10. ICD-10, impulse control disorder. Pyromania to set fire, kleptomania to steal, trichotillomania pull hair. Okay. Intermittent explosive disorder, sudden outbreak of anger. Gambling disorder. These were impulse control disorder according to ICD-10, but ICD-11. Trichotillomania is obsessive compulsive and related disorder. In ICD-11, gambling disorder is now addiction. Point it out. So this is a potential question not asked till now. So gambling and gaming are addiction according to ICD-11. ICD-11 said few behavior may be addictive. Gambling and gaming may be addictive. Gaming may be online, offline. Point it out. Offline, online gaming are addictive behavior. So gambling and gaming, ICD-11 addiction. Which of the following is not classified as OCRD? PTSD is stress, trauma and related disorder. It's not OCRD. Yes, trichotillomania is OCRD. Previously it was impulse control disorder. Hypochondriac disorder, this is important. ICD-10, it was somatoform disorder. Somatoform disorder. If don't remember, it's okay. But now hypochondriasis is OCRD. OCRD. Okay. Fast. ICD-11, kleptomania, pyromania, intermittent explosive disorder. These are same both in ICD-10 and ICD-11. In ICD-10, pathological gambling was impulse control disorder. Now it is addiction. Trichotillomania is OCRD. New entity in ICD-11, compulsive sexual behavior disorder. Yes, patient indulge in sexual activity. After some time, yes, he feel guilty. That is compulsive sexual behavior disorder. Okay. Now, I think it is sorry for some technical issue is there. No, it's okay. Yes. Yes. Obsessive compulsive and related disorder, DSM-5, mnemonic is HOBET. HOBET. Recently asked topic, you can't avoid this table. Yes, hoarding, OCD, body dysmorphic disorder, excoriation, trichotillomania, HOBET. HOBET. ICD-11 added few more entity, mnemonic, HOBE. HOB. HOB is done again and again. So all these disorder, patient do things or thoughts come again and again. Hoarding disorder, accumulate things, non-valuable things again and again unable to discard. Hypochondriasis, yes, previously it was somatoform disorder. Now it is OCRD. Question has been asked. Obsessive compulsive disorder, same. Olfactory reference syndrome, new entity included in ICD-11. Body dysmorphic disorder, same, just like DSM-5. In ICD-11, excoriation and trichotillomania both are jointly called body focused repetitive behavior disorder. Body focused repetitive behavior disorder. Just to highlight this change, although it's really difficult to remember, but at least have an idea that these two, somatization disorder, ICD-10, somatic symptom disorder, DSM-5, ICD-11, the name is bodily distress disorder. So this question can be asked. Means they can give you a same clinical scenario and can give different option in the question. Yes, What is somatic symptom disorder? In this patient present with multiple somatic complaint, patient would say, Dr. Saab, I am having pain abdomen, burning micturition, vomiting, nausea, diarrhea, constipation, yes, pain in the neck, multiple somatic symptoms are there. You will do investigation, you will examine, no, you find no sign, all investigation are normal. Yes, this is somatization disorder, somatoform, yes, sorry, somatic symptom disorder or bodily distress disorder. In this, patient is concerned with somatic symptom. Now, hypochondriasis. Hypochondriasis, another name is illness anxiety disorder. Illness anxiety disorder. Okay. Hypochondriasis or illness anxiety disorder. In this, patient perceive no, yes, minimal or no symptom as sign of deadly disease. Means, I give you example. Suppose a person has yellowish discoloration of urine. He would say, Dr. Saab, yesterday I had yellowish discoloration of urine. You know, this yellowish discoloration of urine occur in jaundice. Jaundice occur due to liver disease. Liver may have cancer. So, Dr. Saab, please do investigate and check me. I might be having cancer. Means, patient is concerned with illness. In this, patient was concerned with symptoms. Question has been asked, what is the difference between these two? In these, the patient is concerned with symptom. In these, patient is concerned with illness, not choti moti illness. Yes, this illness should be, yes, lethal, HIV, cancer, myocardial infarction. That is. So, why I am telling you, giving stress? Because clinical questions are there. And they can give you the same clinical scenario. In place of these two words, they can give option bodily distress disorder. Then according to ICD-11, the diagnosis would be bodily distress disorder. This question has been asked many times. A woman who is 4-day postpartum and displaying symptom of tearfulness, mood swings, occasional insomnia. What is the likely diagnosis? Please do comment. Answer, please. Yes. Postpartum blues. Okay. Wherever you find depressive symptom, mild depressive symptoms, many times they will give in the question the word transient or mild. The answer would be postpartum blues. But in the same question, if they use the word patient is having suicidal thought, yes, anhedonia, guilt, then you will prefer to mark, means serious symptoms, then you will mark the answer postpartum depression. Postpartum depression. And if delusion and hallucinations are there, delusion, hallucination are there, postpartum psychosis, many time in postpartum, yes, postpartum blues, no treatment. Yes, supportive, only supportive psychotherapy. Yes. Postpartum depression, you will treat on the guidelines of depression. Postpartum psychosis, yes, in this you will find that patient is having delusion that I have not given birth to this child. Yes, my child born is demon. Yes, so he was born dead. So there is a risk of harm to baby. So in this case, we will separate the baby from the mother. Okay, and definitely treatment would be on the guideline of psychosis. Okay. This question, yes, before going to question, suppose I am teaching you, suddenly start palpitation, breathlessness, choking sensation. I feel I will die, I will go crazy, my doom day has come. That is panic attack. Yes, symptoms are sudden, severe, spontaneous, so severe that I am feeling I will die, I will go crazy, my doom day has come, प्रलय का दिन आ गया है, मरने ही वाला हूँ. Yes, panic attack. But you will immediately take me to the hospital, AIMS, and all investigation would be done to rule out myocardial infarction. So, in panic disorder or panic attack, always DD is myocardial infarction, asthma, COPD. These are questions. Okay. So, question 25-year-old woman described experiencing symptoms such as palpitation, sweating, shortness of breath, chest pain, sense of impending catastrophe, feeling of impending doom. These are 5 to 6 similar episodes in last month. If recurrent panic attacks are there, for more than, yes, for 1 month, then it is panic disorder. Yes, recurrent panic attack Panic disorder. You remember, YouTube, usme the person was doing paragliding, and after he started paragliding, he developed a panic attack, and he started saying, I will give you 500, please land kara de, hai na? That was panic attack. Usually panic attacks are spontaneous, but sometimes they may be precipitated, just like in that boy that was precipitated. Yes, in panic attack, if panic attack is coming again and again, normally we usually say panic attack is episodic anxiety. Episodic anxiety which lasts for 20 to 30 minutes, at few places 15 to 20 minutes, 5 to 20 minutes. Yes, 5 to 20 minutes. Many times you will find that panic attack, there is episodic anxiety. In between panic attack, patient is normal. But if panic attacks are so frequent, patient will start having anxiety that this attack may come anytime. This is called anticipatory anxiety. Anticipatory anxiety. So panic disorder is multiple panic attacks in last month, yes, for 1 month, plus anticipatory anxiety. No question, but they have asked this question many times, so they can ask this. Depression ke symptom you all know, but I will make a mnemonic, EMI. Now I am going to discuss very, very important topic, depression, in which questions are asked and they change only 1 or 2 words and answer is totally changed. So I want your maximum attention, okay, at this time. So I am not taking your answer and not commenting on your yes answer, it is correct or not. Sorry for that, because I want to cover more and more topics, okay. But whatever doubt you are having, I will try to solve. If you have doubt, definitely I will solve that, okay. EMI gaps cause depression, okay. E for energy, low mood, low interest. G for guilt. A for appetite, decrease appetite. P for psychomotor activity, decrease sleep, suicidal thoughts. S for suicidal thoughts. C for concentration. For the time being, I would say out of these symptoms, according to DSM-5, out of these symptoms, if 5 symptoms are there for 2 weeks, then diagnosis is depression. In this depression, if I say 5 symptoms are there for 2 weeks, diagnosis depression plus delusion, then depression with psychotic symptom. Depression with psychotic symptom, okay, or psychotic depression. This question has been asked recently. A young boy displaying symptom of low mood, sadness of mood is there, decreased energy is there, decreased interest is there. Yes, not eating means decreased appetite. His thought include, I have lost my head, I am diseased, how can I eat? Yes, world is ending, my body is rotten, my intestines are rotten. These are delusion of nihilism. Delusion symptom, yes, these suggest delusion of nihilism. Okay, what was the exact question we don't know, but yes, this is delusion of nihilism, nothing is left. If delusion of nihilism plus depression, then it is called Cotard syndrome. So in this, depressive symptoms are there, depression are there, yes, plus delusion of nihilism, then it is Cotard syndrome. Okay. Yes, this flow chart, very, very important. If 5 symptoms are there, these 5 symptoms are there, okay, means diagnosis of depression is made. If 5 symptoms are there for 2 weeks, then we say major depressive disorder. We say major depressive disorder or depression or unipolar depression. In the same question, means this is flow chart to tell you that how questions are asked. They gave the patient is having low mood, decreased appetite, decreased psychomotor activity, decreased sleep, decreased interest. 5 symptoms are there, 2 weeks, diagnostic criteria of depression is fulfilled, major depressive disorder. In the same question, they mentioned that these symptoms are there and there is previous history of similar episode. Then depression is occurring again and again, recurrent depressive disorder. If same 5 symptoms or different 5 symptoms they gave and said that patient is also having delusion. Yes, you will say psychotic depression, depression with psychotic symptom. In the same question, I would add that patient has history of schizophrenia within 1 year. Within 1 year, this is very, very important. Within 1 year, schizophrenia history is there. You will say post-schizophrenic depression. Post-schizophrenic depression. Okay. If these symptoms are present for 2 years, then it is chronic major depression. If only 3-4 symptoms are there, depression diagnosis is not made. Yes, let me describe in this way. Suppose a patient came to me having 5 symptoms of depression for 2 weeks, then I will make the diagnosis of, yes, diagnosis of depression or unipolar depression. If patient said that these symptoms are there plus delusion is also there, so psychotic depression would be there. If patient says that these 5 symptoms are present for 2 years, then it is called chronic major depression. Chronic major depression means major depression which has become chronic. If a patient comes to me having depressive symptoms but don't fulfill the criteria of depression, depression criteria is not fulfilled and these symptoms are present for 2 years, then this is called dysthymia. Dysthymia. Yes, so if only 4 symptoms are there, suppose I say only 4 symptoms are there for 2 years, then the diagnosis is dysthymia. Now, if these symptoms are there, 4 symptoms are there after breakup, if you don't remember it, not able to understand, don't worry, I will give you example in the form of question, then you will understand. After stressor, just like divorce, after breakup, after financial loss, after medical illness, suppose a patient is having low mood. After breakup, it's quite common, low mood, decreased interest, decreased appetite, means these 4 symptoms are there, means don't fulfill the criteria of depression. I told you to fulfill the criteria of depression, how many symptoms should be there? 5. So 4 symptoms are there, diagnostic criteria of depression is not fulfilled. After breakup, you will say adjustment disorder. You will say adjustment disorder, point it out. Means patient is not able to adjust this stressor, adjustment disorder. But after breakup, if depression criteria is fulfilled, diagnosis would be depression. Yes, now you will tell me the answer. Okay? Yes. 40-year-old woman was divorced by a husband, stressor is there, divorce, present in psychiatry OPD, appears sad. First symptom is sadness of mood, first symptom is sadness, decrease interest in activity, second symptom decrease activity, she used to enjoy, yes, this is anhedonia, not getting pleasure in previously pleasurable activity. Question has been asked, what is anhedonia? Anhedonia, not getting pleasure in previously pleasurable activity. Yes, she report difficulty in concentrating, concentration is low. So 3 symptoms. 4th symptom sleep, appetite, 5th symptom energy are decreased, 6 symptoms are there, more than 5 symptoms, more than 5 symptoms are there for more than 2 weeks, more than 5 symptoms for more than 2 weeks. Diagnosis is, yes, diagnosis is major depressive disorder. Diagnosis is major depressive disorder. Very good. In the same question, a 40-year-old woman divorced, first symptom, second symptom is there, third symptom is there, 4th, 5th, 6th are normal, only 3 symptoms are there, only 3 symptoms are there. Yes, diagnostic criteria are not fulfilled. Yes, in the same question, I change this decrease to normal, means only 3 symptoms are there after a stressor, 3 symptoms are there, means diagnostic criteria not fulfilled. I told you after a breakup, after a stressor, divorce, if diagnostic criteria depression not fulfilled, the diagnosis would be adjustment disorder. So answer would be adjustment disorder with depressed mood. Now, same question. Yes, patient present with this sadness is there, interest is low, concentration is low, sleep, appetite, energy is low. But these symptoms are present for 2 years. 2 years. Diagnosis is, yes, chronic major depression. For 2 years, diagnosis is chronic major depression. Yes. 2 years, but sleep, appetite and energy are normal. Yes, means depressive symptoms are there for 2 years. Depressive symptoms are there for 2 years, but diagnostic criteria not fulfilled. Diagnosis is, yes, dysthymia. Diagnosis is dysthymia. Yes, I am not getting answer. Yes, Neha, Ramesh. Yes, same scenario they gave and they added occasional hallucinations are there. Occasional hallucination are there, depression plus hallucination, psychotic depression. Psychotic depression. Okay. Psychotic depression. Now, same question. Yes, occasional hallucination means depressive criteria fulfilled. Occasional hallucination is there and history of schizophrenia in last 6 months or within 1 year, the diagnosis would become, yes, diagnosis would become post-schizophrenic depression. Question is asked, post-schizophrenic depression is having high suicide risk, okay, and suicide rate in schizophrenia is around 10%. Same clinical scenario and they gave history of similar episode 1 year back. Diagnosis would be, yes, recurrent depressive disorder. Again and again depression are there. New update, we know so many antidepressants and you know that antidepressants are chosen on the basis of, yes, chosen partly on the basis of side effect profile. Synopsis latest edition, they have given choice of antidepressant partly depends on the side effect profile. Question has been asked, 11th edition, yes, antidepressant are chosen on the basis of side effect profile, but latest edition partly. This may be asked. Paradoxical suicide. Yes, suppose a patient is in severe depression. Suppose a severe depression is there. He is having decreased energy, decreased interest, low mood and having suicidal ideation. Patient is having suicidal ideation, want to commit suicide but he is not having energy. You admitted the patient, you started the treatment. When you started the treatment, patient is improving, his energy is improving. Yes, now suicidal thought is still present. I give you example. Suppose a patient is having suicidal thought, but he is not having energy. He says, who will go to market, who will buy rope, who will hang himself, will not commit suicide. But you started treatment, patient started improving, energy is improving. Now he will go to the market, will buy rope, will hang himself. Yes, this is called paradoxical suicide, means suicide is more in recovery phase, because in recovery phase, suicidal ideation is still present, but energy improves. So, yes, paradoxical suicide, suicide occurring at the time when patients start to recover. Yes, this question, please do comment. A patient was treated with tricyclic antidepressant for severe depression episode in hospital for 4 weeks. Now, we want to discharge patient. What is the main concern? You know, when patient is having severe depression, suicidal ideation is there. Yes, you will not discharge the patient. Before discharging, always assess suicide risk. Yes, suicide risk assessment is done because we know that suicide is more in recovery phase. So, main concern is suicide risk. Okay, in this confusion was there. What was the confusion? Because whenever we start the patient on TCA, we always monitor TCA. Before starting TCA, we do ECG. After 7 days, we do ECG. And we do ECG whenever we increase the dose of TCA. So students were confused that in TCA we should monitor the patient for ECG by ECG for arrhythmia or toxicity. But when we discharge patient on the same dose. And guideline says that we should monitor ECG when we want to increase, when we are increasing the dose of TCA. So at the time of discharge, we are not increasing the dose of TCA. So this option is not valid. Now, first, if mild depression, treatment is CBT plus exercise. If moderate severe depression, best treatment is CBT plus antidepressant. Antidepressant, we prefer SSRI on the basis of side effect profile. Now we say partly on the basis of side effect profile. Moderate severe depression plus psychotic symptom. Please do comment. In this, we will give, yes, antidepressant plus antipsychotic. Yes, antidepressant will take care of depressive symptom, antipsychotic will take care of psychotic symptom. If patient is not improving, then we will use ECT, modified ECT. Okay. Severe depression with suicide, wherever you find the word suicide, immediately answer is ECT, modified ECT. Depression with suicide, ECT. Schizophrenia with suicide, ECT. Depression with catatonia, ECT. Catatonia best treatment is ECT. Neurolapse malignant syndrome, ECT. Okay. Now, pregnant patient with suicide. Yes, do comment. ECT. Can we give ECT? Yes, ECT is safe in all trimester of pregnancy. This is myth that we should not give ECT in pregnancy. We give ECT. ECT is very safe in pregnancy, all trimester. Point it out. Treatment resistant depression we have, yes, option modified ECT, yes, RTMS and vagus nerve stimulation. Yes, modified ECT, why I am telling you again and again, modified ECT. Previously we used to give direct ECT, we used to take electricity wire, put here, straightening of hair. Yes, that is direct ECT, means that was so painful and so much strong muscle contraction, fracture bone may be there. That's why according to Mental Health Care Act 2017, you can't give direct ECT to any patient. If you want to give ECT, you will give general anesthesia plus muscle relaxant. General anesthesia plus muscle relaxant. General anesthesia question has been asked, methohexital, and yes, muscle relaxant, succinylcholine. Yes, when general anesthesia is there, patient should be unconscious. So when image based question is asked, patient would be unconscious and there would be mouth gag. Why mouth gag? Because you are producing seizure. Seizure, there may be tongue bite. Sometimes image based question is asked and they will ask, this image show ECT. Because in this you are giving ECT, so there should be mouth gag, because mouth gag prevent tongue bite. Okay, this is ECT machine. One indication I have told you, treatment resistant depression. RTMS, recurrent transcranial magnetic stimulation. In this we stimulate the desired area of brain by magnet. Yes, in this no seizure, no need of giving general anesthesia. Patient is conscious. And this can be used as monotherapy in treatment resistant depression. Then vagal nerve stimulation. Question can be asked. Yes, which vagus nerve? Left vagus nerve is stimulated, cervical area is stimulated. Vagus nerve stimulation was first used for treatment refractory seizures. Patient was not responding to treatment, seizure patient. So what we did vagus nerve stimulation. Patient is treated and started becoming happy. So we thought, why we should not give vagus nerve stimulation to depressed patient who are treatment resistant? So patient who is treatment resistant, we can give vagus nerve stimulation, but it is invasive procedure. So it should be kept in the last, only and only when more than four antidepressant trial failed. Okay. Now you can ask, give me answer. Yes, please do reply. patient is having depression and history of mania 1 year back. Depression and mania, both poles are touched. Answer is yes. Answer is BPAD 1. Same question, history of hypomania 1 year back. Answer would be yes, BPAD 2. I have given so many questions. Yes, all these options I have explained the same question with little bit modification. Trust me, questions are being asked in such a way they will change little bit language and the answer would change. So you will keep in mind. So if depression and hypomania, BPAD 2, depression and mania, BPAD 1. Yes, again a very important question you can easily answer. 23-year-old girl is brought to psychiatry OPD by her mother because 5-month history of feeling sad. Sadness, 1 symptom. Sleepless, 2 symptom. Focus on work, 3 symptom. Concentration is decreased. She feel tired, 4th symptom. Yes. Eaten very less, 5th symptom. Past symptom, 5 symptoms and hearing voices. Means depressive criteria fulfilled and hallucinations are there, means psychotic symptom is there. Diagnosis is depression with psychotic symptom. Diagnosis is depression with psychotic symptom. Now, this question, complete question, yes, depression criteria fulfilled and patient is having symptoms of, yes, schizophrenia. Delusion is there, delusion of persecution is there, hallucination is there, schizophrenia. So both schizophrenic symptoms are there and depressive symptoms are there for most of the duration. For 5 months depression is there, for 7 months schizophrenic symptoms are there. Most of duration both depression and schizophrenic symptoms are there. Schizoaffective disorder, schizoaffective disorder. Okay, next question. Please tell me the answer. Yes. 18-year-old boy recurrent intrusive thoughts which he perceives to be senseless and involuntary. Patient wants to stop but can't stop. He starts believing these thoughts are being inserted. Yes, these thoughts are being inserted. Which of the following diagnosis must be considered? Yes, thoughts are being inserted. Thought insertion. Thought insertion is seen in schizophrenia. Answer is schizophrenia. In the same question, if I say that patient believes these thoughts are his own thoughts, what is the answer? Yes. What is the answer? The answer would be OCD. In OCD, thoughts are my own thought and somebody is inserting these thought insertion. In the same question, if I say these thoughts start before seizure and ends with seizure, then diagnosis would be force thinking. Yes, frontal lobe epilepsy. In frontal lobe epilepsy, there is force thinking. Okay. Disorder of possession of thought, mnemonic, possession, obsession. This is controversial. Obsession is disorder of possession of thought. Few books says it is disorder of, yes, possession. Few books says it is disorder of content. But you will go with possession. Obsession, possession. Thought alienation are disorder of possession, mnemonic. Yes, P for possession, P for PK. PK movie, he was alien, he was having radio matlab broadcasting. Yes, thoughts are being broadcasted just like radio station thought broadcasting. Thought insertion, thought withdrawal. This is mnemonic that in PK movie, yes, he withdrew all the thoughts. Yes, he was thinking something else, insertion, but actually withdrawal of thought was there. So these are disorder of possession. Formal thought disorder, single liner question has been asked many times in INI-CET. You will remember form as platform, and anything related to train, that is formal thought disorder. Fast revision, yes. Derailment, rail is derail, derailment, yes. Formal thought disorder. Loosening of association, दो डब्बों के बीच में association lose हो गया. Complete loss of organization, accident हो गया. Yes. Tangentiality, you must have seen toys having this tangent path, tangentiality. I know it would take little bit much time to explain each and every disorder, formal thought disorder, but most of time you will find question that which of the following are formal thought disorders. So you will remember like this: neologism, neology, new bogey, neology, new bogey, nai bogey. Okay. Other than that, circumstantiality, perseveration, thought block, all these are blocks. So thought block, perseveration, repeating the same thing again and again. What is perseveration? Yes, question has been asked. Suppose I ask, what is your name? Patient says, my name is Mahesh. Where do you live? My name is Mahesh. What is your father name? My name is Mahesh. Means thought is continued beyond the point of relevance, perseveration, same question, Mahesh, Mahesh, Mahesh. Most of time you will find wherever Mahesh is there, answer is perseveration, and if perseveration is there, there is chance of organicity. Okay. Circumstantiality, this is circumstantiality, grooming again and again, again and again, like that. Okay. So these three are controversial according to, yes, Kaplan, these are formal thought disorder, but Fish psychopathology says these are disorder of flow, disorder of stream of thought or flow of thought, stream, disorder of stream or flow. I have taken care in formal thought disorder because many time in clinical question, thought block has been considered as part of formal thought disorder, and in schizophrenia clinical scenario, you will find thought block in the question. So thought block, formal thought disorder. So these three are controversial. If question is asked, according to me, if question is asked, these three are formal thought disorder. If formal thought disorder are not given in the option, then you will say that these are disorder of stream or flow of thought. In the same way, if obsession is disorder of possession of thought, best answer. If possession not given in the option, then content of thought. This is again important question. Complex hallucination, hallucination in more than one modality. Hallucination more than one modality, just like you must have seen Lage Raho Munna Bhai. Yes, he was seeing Bapu and hearing Bapu, means hallucination in vision, hallucination in auditory. So more than one. Tactile hallucination, yes, cocaine bug, yes, after taking cocaine. Cocaine is a very interesting substance. Why interesting? Because Sigmund Freud introduced cocaine in psychiatry. Sigmund Freud said that if a patient is dependent on opioid, so I will discuss little bit about the opioid and all these things. Okay, opioid, dependent on opioid, give him cocaine, he will be free of opioid, and now he will dependent on cocaine. Okay, so first question, that cocaine was introduced in psychiatry by Sigmund Freud. If you take cocaine, many times you will feel that insects are crawling over the skin. You will have tactile hallucination. You will feel means tactile hallucination. Point it out. Now, if you see, then it is visual hallucination. Please give me answer. Yes, please give me answer. Yes, yes. In this question, a 20-year-old boy has been taking cocaine. Yes, for last 2 years. Now he has jet black tongue. Yes, what is the color of Coca-Cola? Black. So if you take Coca-Cola again and again, cocaine, yes, previously cocaine was present in Coca-Cola. Okay, if you take Coca-Cola again and again, your tongue would be black, jet black tongue. His BP is increased, pulse rate is increased. He sees insect crawling over his body. Yes, please do reply. Yes, this phenomena of perception is, point it out, sees. Yes, read question carefully. Sees, the answer would be visual hallucination. In the same question, if they say that patient feels, then the answer would be tactile hallucination. So read question carefully, my dear friends. I am telling you, in all the questions, they are giving question in such a way that they change only one word and answer is changed. If they say sees, then it is visual hallucination. If they say feel, it is tactile hallucination. If they say both sees and feel, then it would be complex hallucination. Okay. And one more point here, opioid intoxication. I discuss opioid intoxication. There is triad of opioid intoxication is pinpoint pupil, respiratory depression and coma, death. Death usually occur due to respiratory depression. Question is asked in opioid intoxication, what is the initial management? You know death occur due to respiratory depression, so you will secure airway. If question is asked opioid intoxication initial management, then secure airway. Secure airway. If question is asked what is the drug of choice, IV naloxone. IV naloxone. One more point, yes, in this BP is increased, pulse rate is increased in cocaine. Cocaine, what is the mechanism of action of cocaine? Yes, let me discuss here. What is the mechanism of action of cocaine? Cocaine inhibit the reuptake of norepinephrine and dopamine reuptake inhibition. So norepinephrine increases. When norepinephrine increases, it will cause tachycardia. Tachycardia. Recently asked question that which is not side effect or symptom of cocaine intoxication. Option was bradycardia. Answer was bradycardia is not symptom of cocaine intoxication because norepinephrine will cause tachycardia. It will cause vasoconstriction. So if you are taking cocaine, vasoconstriction of coronary artery, there may be myocardial infarction. Mydriasis would be there. Okay. So these are few questions recently asked. Advance directive, this is again question. Yes, in Mental Health Care Act 2017, I can make advance directive a legal document in which I can direct कि in future if I develop any psychiatric illness, I should be treated on these guidelines. Means legal document made by the patient, yes, how they wish to be treated, not treated for mental illness in future. Okay. Means suppose I may at this time I am having intact decision making capacity. I make advance directive that if in future I develop schizophrenia, I develop suicidal ideation, never give ECT. Give this treatment, don't give that treatment, give this treatment, don't give that treatment. I gave a complete list. Now, in future, what happened? I developed schizophrenia. I am having suicidal thought. I came to you and ask that doctors, yes, my friend brought me to you and ask that Dr. Saab, please give ECT. And I have already given that never ever give ECT to me. So you will never give ECT. Yes, I mentioned one person as nominated representative that in future if I develop any psychiatric illness and I have not written in this legal document, you will ask my friend Maggu nominated representative. Means if anything is not written in advance directive, you will follow nominated representative. Okay, last question for the day. Which of the following condition is solely observed in female? Rett syndrome. Rett syndrome is X-linked dominant, X-linked dominant. Previously we used to say that it is only seen in, exclusively seen in females, but now say female more than male because few male patient having Rett syndrome has been observed. This is X-linked dominant and in this there is microcephaly. Microcephaly. And 70% patient have seizures and there is treatment. Recently asked question, drug approved by, yes, FDA is trofinetide. Okay friends, thanks for patience listening. Now one doubt was there not related to the subject, that every time, yes, I am not getting good marks in grant test. All notes has been revised. Dear friends, never ever judge yourself on the basis of grand test. I usually say that grand test is for your evaluation of those mistakes which you are going to do in your main exam. So initially, if I say initially, grand test was the concept of grand test was that ki in exam we are stressed, we make silly mistakes. Okay, that this is the reason we introduced grand test, that whatever silly mistakes you are going to do in your exam, you will do at this time and you will recognize that and you will not make those mistakes again. So one thing, yes, you will point out which topics or which subjects are weak, because after completing your grand test, yes, you will invest 2-3 hours that what mistake, silly mistake you have done, which subject is weak, which topic is weak, and do work on that. Got the point? This is the, I think that this is the main thing which is required from grand test. And nowadays there are discussion of grand test. Every time you have discussion of grand test, do attend that and you will find so many added questions and you will improve your score. Second thing, I feel that many times students do revise notes and they don't attempt questions. So PYQ, PY topic you should attempt and this will improve your score. Thank you for your patience listening and best of luck for your exam. Thank you.